So we welcome Dr. Prasad to start his presentation. I'm sure it's going to be an interesting one.
Since it is the last talk of today, I will take the liberty of taking few more minutes. And good afternoon, respected chairpersons, all my seniors, and all the audiences. At the onset, I would like to thank organizing committee of API Midas for giving me this chance, especially Dr. Mukhewar sir and Nikhil Balanke sir for letting me present this very important topic of intensive care challenges in a patient with ACLF. Now, ACLF is a recently identified entity, like a decade back it has been, as a clinical entity has been identified. It is basically a clinical syndrome which happens in almost 1/3 of the cirrhotic patients. It is a systemic inflammatory disease which is driven by a dysregulated immune system which causes organ dysfunction, much similar to that of sepsis. Now this organ dysfunction and systemic inflammation is the thing which differentiates it from acute decompensation that otherwise would happen in a cirrhotic patient. Now ACLF is associated very high short-term mortality. Unfortunately, there are no definitive evidence-based guidelines which will help us to treat, and most of the guidelines have been adopted from general ICU patients. Now, defining ACLF, different organizations have given different definitions for ACLF. The most prominent of them are EASL and North American, Asia Pacific, and World Gastroenterology. Out of these, EASL, North American, and World Gastroenterology's definitions are more organ failure centric, while that from APASL is more a liver centric definition. The most followed one is that given by EASL, though it is not universally accepted. By the EASL, the definition is acute decompensation, which may be there on a previously decompensated or undecompensated patients along with organ dysfunction, any one organ dysfunction. Now, the organ dysfunction criteria are generally judged by CLIF C score or CLIF SOFA score, which is nothing but a modified SOFA score. The modified SOFA score has got a better predictor of severity as compared to MELD sodium or child's classification. The grading of the severity is generally done by the amount of the number of organs that are involved. Early identification. Now, definitely, the risk the patient the ACLF patient should be identified beforehand, because it has been proven that there are better prognosis if early identified and ICU admissions. The data of discharges of such patients have shown almost 68% of shift out from ICU and 52% from hospitals, and it was mostly attributed to the quality of care and early admissions. What are the precipitating factors? Now, definitely a precipitating factor should always be sought of for such patients. There are infective as well as non-infective etiologies, and the most prominent one are reactivation of viruses, alcohol intake in last 4 weeks, and sepsis. Now, almost 40% of patients, we don't find any precipitating factor, and it has been neither linked with disease severity nor with mortality. Whenever such patients are admitted, we should first stabilize this patient. Now, first step in stabilizing is always airway management. Such patients generally need intubation for severe HE grade, generally West Haven grade more than grade 2 or GCS score of less than 8. Apart from this, intubation is always needed to facilitate endoscopy for variceal bleed or for respiratory failures. Now, one thing we have to keep in mind to minimize sedation because of the prolonged hepatic clearance of drugs, which will require prolonged ventilation. Not to forget is other pathologies like pulmonary, protopulmonary hypertension as well as hepatopulmonary syndrome, especially in patients where hypoxia is out of context of the clinical picture. Whenever we ventilate such patients, we should always follow lung protective strategies, but then with ascites and hydrothorax, it may be difficult at some times. Cardiovascular changes now, the cardiovascular changes in such patients are typical hyperdynamic circulation. The systemic vascular resistance is low, there is effective central hypovolemia and low arterial pressure, though the cardiac output is elevated. Now I can just imagine what a minor insult can do to such patient. Something like GI bleed or a minor infection can precipitate a massive cardiovascular collapse. Now, also, the things can be complicated by associated cirrhotic cardiomyopathy. Now, whenever such patients are in ICU with shock, what resuscitation fluid should we use? Now, there are no direct RCTs which have compared different resuscitation fluids, but crystalloids are the one which of choice. Now, among the crystalloids, balanced salt solutions, they have upper hand over normal saline, because normal saline have got a propensity of metabolic acidosis, hyperchloremic metabolic acidosis. Though balanced solution have a theoretical chance of lactate accumulations, but then that is more theoretical than practical. As far as starches are concerned, it is a big no. We should not be using starches because it worsens the renal failure as well as the coagulopathy. Now, something about albumin in ACLF. Albumin production, the rationale of using albumin in such patient is generally impaired production as well as the quality of the albumin that is being produced. Apart from that, it has a colloid property. It reduces systemic inflammation. Antioxidant property is also there. The use of albumin to treat spontaneous bacterial peritonitis and renal failure has been proven beyond doubt. But these results have not been found outside SPP-related sepsis. And the cost is always a concern while using albumin. Such patients should always be assessed for fluid status as well as for fluid responsiveness. Whenever we talk about fluid responsiveness, generally there are two things, static parameters as well as dynamic parameters. Now, static parameters have been shown to very poor correlation with fluid responsiveness. They have their own disadvantages, and to add to them, the cirrhotic patient further complicates these things. So static parameters are generally not very indicative of fluid responsiveness. So what about dynamic parameters? Dynamic parameters do have a better hemodynamic outcomes, but then they are also not free of their limitations. They cannot be used in spontaneously breathing patients or with patients with cardiac arrhythmias. Apart from this, most of these techniques have not been validated in an ACLF patient. But some form of fluid responsive technique should always be used. What vasopressors to be used in ACLF? Now, there are no direct RCTs which have compared, but by going by surviving sepsis guidelines, noradrenaline should always be the first choice. To use epinephrine is a big question because epinephrine causes excessive splanchnic vasoconstriction, which may worsen liver failure. As far as second vasoconstrictor concerned, vasopressin is the choice. Terlipressin in setting of a shock. Now, terlipressin is, as we all know, terlipressin is a synthetic analog of vasopressin. It specifically acts on V1 receptors and increases central volume. Now, there are two trials which have directly compared terlipressin with noradrenaline, and terlipressin have shown a survival benefit. But then we need further validation for this. So at the moment, terlipressin is a valid alternative for norepinephrine only in the cases where the requirement of vasopressor is very low, or as an adjunctive therapy where there is refractory shock. Terlipressin, whenever used, should always be used as a continuous infusion. Now, AKI, renal failure is the most common extrahepatic organ failure that happens in ACLF patients. Now, it is generally of two types, HRS AKI as well as non-HRS AKI. HRS AKI is the one classical pathophysiological renal failure that happens in a cirrhotic patient and is generally a pre-renal. Non-HRS AKI can be pre-renal or post-renal depending on the etiology. Many a times overlap does exist, and they are again superimposed on underlying renal, intrinsic renal disease. Whatever it may be, it is a very strong predictor of poor survival. Now, clinical approach for AKI is first is to exclude obstruction, any nephrotoxic medications, or decompress tense ascites. Second thing would be definitely optimizing circulating volume, and we have to use albumin in dose of 1 kg per body weight for almost 48 hours. If there is no improvement with this, then you have to add a vasoconstrictor. Again, terlipressin fares better over noradrenaline as a vasoconstrictor in these conditions. Renal replacement therapy, need of renal replacement therapy itself is a very poor predictor. Now, no survival benefit has been found in patient who have got renal replacement therapy against who have not got renal replacement therapy. And even if it helps, it only does in the patient who have non-HRS AKI. Again, this decision should be very individualized. Acute confusional states are again very common, and most common cause of acute confusional state is overt hepatic encephalopathy. There are other causes should always be kept in mind, especially intracranial bleeds for this patient are prone. Now, approach for altered neurological state is always airway protection. Is the first, where we have to intubate the patient for grade 3, grade 4 hepatic encephalopathy. You should always minimize sedation for facilitating early extubation. Propofol is the preferred agent, while benzodiazepine should always be avoided. A low threshold should be kept in mind for these patients, especially those who have abrupt onset of altered mental status or have focal neurological signs. Now, as well as treating overt hepatic encephalopathy, again, there are no rigorous trials, but ammonia-lowering therapies should always be started. Lactulose is the first choice. We can always add rifaximin, branchial amino acids, and LOLA. Infections are very common in these patients. Infections are both precipitant as well as complication of ACLF. Most common of them are SBPs, pneumonias, and UTIs. The bacterial infections are more common than fungal, and there is high prevalence of nosocomial as well as MDR infections. These patients are very prone to go into severe sepsis. While treating infection, one should always follow the antibiotic stewardship to maximize the effect. Now, basic coagulation defect, ACLF is both antithrombotic as well as prothrombotic condition. There is balanced reduction in both pro as well as anticoagulant factors. In thrombocytopenia, also due to increased von Willebrand factor and reduction of Adams 13, the chance of spontaneous hemorrhage is very low. The hemorrhages are always due to the portal hypertension. And again, these changes in ACLF are very fragile. As far as plasma-based standard laboratory test versus vesicoelastic tests, plasma-based tests are very poor predictor of both spontaneous as well as procedure-related bleeding. Vesicoelastic tests like TEG and ROTEM, they give us more comprehensive picture because they are done in whole blood. There are 2 RCTs which have used TEG-related guiding transfusion practices, and it has shown significantly low requirement of blood products. What glycemic target should one follow? Now, these patients, 30% of these patients are clinically diabetic and have insulin resistance. Apart from this, they are also prone for hypoglycemia. So, setting a glycemic target is very difficult for these patients. What is generally preferred is keeping them between 144 to 180. Nutritional concern. Now, these patients are malnourished because there is altered lipid, protein, as well as carbohydrate metabolism due to inadequate intake. Protein-calorie malnutrition is very prevalent, and it is a poor prognostic indicator for mortality. Now, there are no specific guidelines for nutritional replacement, but what are the general guidelines for other patients should always be followed. Now, use of corticosteroids, 1/3 of these patients have evidence of adrenal insufficiency. But again, the evidence for support of using corticosteroids is very less and cannot be used for every patient. Corticosteroid should only be used as a rescue therapy for cardiovascular support. Now, liver transplant, it has been already talked by Dr. Mohanka, but I'll just say that these patients were initially not thought of liver transplant because of associated other organ dysfunctions, but these things now need to be reconsidered because there is one study have shown 80% survival of these patients, especially grade 3 ACLF, though it is significantly low when the patient have been electively transplanted. Plus, there is greater post-transplant morbidity in such patients. Time to transplant is again controversial. In an observational study, The patient who had 1 year post-transplant survival were always transplanted within 1 month period of being admitted to ICU. So whenever these patients are admitted after their initial stabilization, they should always be worked up for transplant. And the ideal clinical window to transplant is from day 7 to day 14. Novel therapies like extracorporeal liver devices like MARS and immunomodulatory therapies all have been tried, but there is no survival benefit from these therapies. If considered, they should always be considered as a bridge to liver transplantation. Plasma exchange have shown benefit as far as acute liver failure is concerned. As far as ACLF is concerned, the trials are ongoing, and we need to wait for the results. Now, for conclusion, ACLF is now a distinct clinical entity with a very high short-term mortality. The main principle of treatment would be treating the acute precipitant and provide organ support. The approach to transplant should be reconsidered, and further studies in these cohort patients are needed. So I will thank for your patience listening, and would be happy to take any questions.
Thank you, Dr. Prasad. That was indeed a very comprehensive coverage of management of critically ill patient, and I really congratulate you for that complete cover. The emphasis, as you rightly said, should be on number one is the resuscitation, in which airway protection is mandatory, and we need to know the indications for airway protection in such situations. Second is fluid assessment and fluid responsiveness, because mostly in liver failure patients, chronic liver failure patients, they are bloated, albumin levels are low. So assessing fluid in this patient becomes a different challenge. Ultrasound or POCUS or VEXUS protocols may not help you much in fluid assessment. So dynamic parameters are more important in that you very well covered that. Third was like anti-edema measures, which you mentioned. And for that, we need to be very careful. And choice of fluids, as you rightly said, amongst that, crystalloids or colloids. In colloids, we can prefer 5% albumin along with adding crystalloid into it. So that is one good option probably for a fluid. And of course, we should be very cautious, and we must keep a very low threshold for infections. Earliest sign of sepsis needs to be picked up, and it is really difficult in such hypoproteinemic states. Very well covered, very nice.
So regarding fluid responsiveness, I'll just say one thing. Whatever method we are using, for example, if we are using pulse pressure variation or stroke volume variation, if we take 10 to 15% as indication for fluids, for a cirrhotic patient, probably we should be on a higher side. Like if it is 15% you give fluids, 10 probably you should not give because they have chances of going to higher hypovolemia. And as far as infections are concerned, we should, whenever these patients are admitted, you should consider them as infected and start the workup for them and start them on higher antibiotics, because they are going to, if they are not infected, they are going to be infected in the due course.
As a gastroenterologist, I think differentiating between ACLF and a patient who is with the natural course of a disease decompensating with the cirrhosis of liver. Now this subset of the patient who are fairly compensated liver disease and they have worsened because of some kind of acute insult. Now their dynamics are different from this decompensated cirrhosis, because as you mentioned that if this patient have a short-term high mortality, if you treat aggressively, treat adequately, you can pull them out, especially in the era of the transplant, where you can offer them permanent cure. I think that is the reason why this topic is more important. One point or one comment which I would like to give is the role of CRRT or plasma exchange, because we are also evolving along with this treatment, and we are seeing that definitely this ACLF patient along with ALF, not just ALF patient, we know that ALF patient CRRT has definitely some role, but even the ACLF patient do well with the CRRT treatment, and definitely we can offer them transplant in near future.
Yes, for that, it has been strictly not strictly rather, they should always be, at the moment they should be used in trial conditions only, because there is no that clear-cut indication for it at the moment. But definitely, as ALF is there, it should help in ACLF as well.
Yeah, congrats Dr. Prasad for an enlightened talk on this ACLF. My question is regarding the 3% sodium used in hepatic NCAF and how much sodium we should keep in such patient.
Regarding sodium, it is a really tricky one because a little more sodium pushes them into ascites. So now there is no clear-cut indication for how much sodium should be given. But yeah, if the patient is has got hyponatremia and there are no signs of it being a dilutional hyponatremia, then you should probably use 3% sodium.
A nice presentation, Dr. Prasad. A complex topic explained in 15 minutes. Nice. As an intensivist, I would like to ask you, what kind of sedation you will use once the patient is on ventilator? What is the preferred sedation in these patients, with the patients are on ventilator?
Definitely, as it has been shown, propofol is the one which is preferred. As far as the guidelines are concerned, they are given propofol should be used. Now newer like dexmedetomidine, it has not been studied as far as cirrhosis is concerned, but otherwise dexmedetomidine for general patient it is very good. But in cirrhotic patients, it has not been studied as that well. So propofol should be used.
What about opiates?
Opioids, short-acting opioids like fentanyl may be used.
Because propofol will have a hypotension if used continuously, and it will need a complex monitoring also, continuous monitoring of blood pressure, because it will have a fall in blood pressure if used.
One thing which overlaps and which is responsible for worsening of these patients of chronic liver disease is tropical illness. And by and large, the patients with cirrhosis, they already have a thrombocytopenia.
Yes,
so in that case, diagnosing or suspecting tropical disease is very important, and we should probably do that, run those studies and actually rule out dengue, leptospira or these things, because the markers will always fool you in that situation. So we should have a low threshold on that. And another important is the renal, actually harnessing those renal parameters for kidneys. And that is a key for fluid resuscitation. Because kidneys will be the first one to get fired with whatever you use. In that situation.
That sense, they should always be considered as non-HRS AKI.
Right.
And probably non-HRS AKI, RRT is more indicated or early indicated in non-HRS AKI rather than HRS AKI, which is more pre-renal.
Yeah. Sir. Two things, what has changed in the paradigm of ACLF is use of this vesicoelastic test, TEG and ROTEM. As a patient coming with bleeding, the transfusion requirement, which RBCs, FFP, cryoprecipitate, has been drastically changed by the use of this ROTEM since we have done start doing. It was not routinely done initially, but now if any patient is having some procedure, some endoscopic procedure, bleeding, we are doing ROTEM regularly, and in some few dates we are seeing the data that the use of this blood transfusion, FFPs, selective use of FFPs, cryoprecipitate has been definitely been very crucial and preventing the patient from going into fluid overload. And second is like what Prasad sir is saying is plasma exchange. Plasma exchange was not very utilized till then, till in Midas Hospital. But since inception of now hepatologists, we have good monitoring, ICU people, for plasma exchange and improving the patient we have seen is also a very important paradigm in the management of this ACLF point of patient. Thank you, sir. Thank you.
Can I make a comment? Yeah, majority of the times when the patient with cirrhosis is decompensated, one has to first think in mind that whether this patient has spontaneous bacterial peritonitis. That's the commonest scenario in clinical practice. And the second commonest is alternative medicines, drug-induced hepatitis. We see flare of Hep B superadded infections like pneumonia, UTI as the cause. Alcohol, of course, is very common, but commonest in practice is SBP, alternative medicines in our set of patients, which is not there in Western countries. The Europeans have given more importance to organ failure, while the Asia Pacific guidelines are different. But I must compliment you for properly covering the Bhushan's comment about use of rotum and plasma exchange. Thank you.
Thank you, sir.
Actually, plasma exchange we tried in last 4 or 5 patients with a dengue with fulminant hepatic failure, with the enzymes of 10,000, 14,000, 27,000, and with the early plasma exchange 3 to 4 cycles, they have recovered wonderfully. So plasma exchange in a fulminant hepatic failure with encephalopathy, that is the indication of earliest plasma exchange. Second is rotem and this take is extremely useful for rationalizing your blood products. So whether you want to use fibrinogen, you want to use platelets or FFP or cryos, so it actually will guide you. And the usual discouragement comes from other consultants who discourage you for not doing rotem because of the cost. But it's a penny wise pound foolish. You do it and save a cost of blood product, irrational blood product transfusions. Absolutely. Thank you so much. Prasad, once again, it's a great lecture.
Thank you, sir.
Thank you.
Thank you, sir, for such an informative session. I request our speaker and chairpersons to kindly collect their mementos. Since we are lagging by 1 hour, we have decided to postpone the last session to tomorrow. So we conclude today's session now.